Hi, good afternoon, everyone. My name is Rehu. I'm one of the alumni leaders and former presidents of National APAMSA, finishing up my cardiology fellowship at Yale this year. I'm very excited to welcome you to National APAMSA's Radiology Bootcamp, the fifth in our Bootcamp series this year, to be followed by Family Medicine tomorrow. Radiology is particularly important because it's a gateway to understanding the human body in ways that few other fields allow through multiple modalities, X-ray, CT, MRI, ultrasound, to name a few. Radiology is the hub of the hospital, the bridge between specialties whose interpretations shape and alter patient management. Therefore, our stellar residents and fellows, Doctors Jennifer Huang, Bianca Ho, and John Liu, have designed today's bootcamp not just for incoming radiology interns, but also for incoming medicine and surgical interns, offering you practical approaches to common issues such as pre-medication ordering and chest X-ray interpretation. Thank you for coming today, and I'll hand it over to Rihanna, our current MD PhD student and professional development director, to orient you to today's format.
Hello, everyone. Thank you, Ray, for the introductory remarks. My name is Elise, and we have Rihanna here, and we're both the moderators for today's Radiology Bootcamp. This is the 2024 National APAMSA Radiology Bootcamp hosted by our wonderful alumni, resident, and fellows. And we have curated a list of high-yield topics that Dr. Huang, Dr. Liu, and Dr. Ho have planned for today. Again, as Ray mentioned, this is a part of a 6-part series of the APAMSA National Bootcamp series. And tomorrow we do have family medicine. So please register if you're interested. In your chat box, while one presenting resident or fellow speaks, the remaining 2 non-presenting speakers will answer your questions in the chat box. We do encourage you to ask questions and also answer questions. If you are an audience member and want to answer a question from your peer, please announce your name, school, and year of training. Please tell us how we can improve next year. This includes technological features, advertisement, and as well as feedback for our speakers today who generously volunteered their time to host this bootcamp series for you. And I'm going to start it off by introducing our first speaker today. We have Dr. Bianca Ho.
Hi, everyone. Happy to be here today. So I grew up in a suburb of Boston. I went to McGill for undergrad, and then I went to Albert Einstein for med school with Rihanna, actually. So currently I'm a resident at UPenn. I'm a third-year radiology resident, so I've got one more to go. My future plans are I've already accepted a spot as a fellow in abdominal imaging at Brigham for after residency. And outside of work, I like to travel, do all kinds of art, puzzles, trying new restaurants. I'm a huge foodie and just, walking around everywhere. And that's me, and then me and my husband and my cat.
Next, we have Dr. Jennifer Huang.
Hi, everyone. My name is Jennifer. I'm currently a abdominal imaging fellow at Brigham and Women's. I'll finish in 2 months, so I'll be an attending after that. I've spent some time at Vanderbilt and Duke, as well as in Greensboro prior to this. And my interests are actually quite similar to Bianca's. I enjoy puzzles, eating, traveling, running, and then I enjoy playing with other people's pets, specifically dogs.
And last but not least, we have Dr. John Liu.
Hey guys, thanks for taking the time on your busy Saturdays to come join us for the session. So for me, I grew up in Florida, and then, as my mom likes to say, gradually moved further and further away from her throughout my training. So I was on the East Coast for undergrad and then med school in the Midwest, and then I moved to LA for residency, and then currently I'm in the Bay Area for fellowship. So then in a couple months, I'll be starting as an attending in San Diego. And then just a couple of pictures. So just recently got married, or I guess not as recently, but in August last year got married. And then me and my wife do like some interests, but mostly eating sushi. So there's just a picture of a sushi place that we went to that was quite good. Thanks.
And without further ado, I'm going to pass it off to Dr. Bianca Ho to start us off with radiology careers.
All right, so I'm going to share my screen. My screen sharing button has disappeared.
Maybe you can like go out and come back in, see if that works.
Yeah, I'm going to leave and come back. Give me 1 second.
And if that doesn't work, John or Jennifer, do you have access to Bianca's slides?
Yeah, we do.
Okay, so that could be a backup plan.
Yeah, I will load them just in case.
All right, so everyone, sorry about that. Totally disappeared. All right, so I'm going to go ahead and get started because I got a lot of material, but please interrupt me if anything isn't working as planned. So I'm going to start by talking about radiology basics and the chest radiograph. So again, I have a lot of material, but I will be uh, racing through it so you guys can get through it all. So I'm going to talk about radiology careers. I'm going to do a radiology primer for non-radiologists and talk about phone etiquette briefly. And then I'm also going to talk about pre-medication for contrast, and then we'll end with the basics of chest radiographs. So like I said, I've got a lot of material, so this is going to be a tour kind of at 2x speed, which I'm sure you're all used to. So let's get started. So a career in radiology, stereotypically, we're always thought of as the doctors that are kind of not real doctors, that kind of sit in the dark, avoid patients, avoid people. And I just love this account on Instagram called My Humorous Life, which is written by a radiology resident. And that just kind of illustrates like the typical, stereotypical idea of a radiologist. But in reality, it's not just sitting in a dark room. We do go into the light sometimes, and we do get up, and it's actually very social because we're always talking to people in the reading room, especially in an academic setting. You'll be with your colleagues, you'll be often with trainees as well. And so it's really never quiet. It can include daily patient contact depending on which field you go into within radiology. And you can, besides just diagnostic imaging, you can actually do a lot of procedures as well as your job. It's seldom boring. So I think even for me, who was going into radiology, when I did my med school rotation, I felt kind of bored because you are just you're not really doing much. You're watching somebody else read scans, which is a little bit like watching somebody else play a video game instead of playing it yourself. So don't necessarily have that turn you away from a career in radiology. Reasons why you might consider it, if you love a good puzzle and you love discussing these with others. It's a lot more medicine and less paperwork. You usually don't have to deal with any insurance. And it's really just you're purely reading scans or treating patients. There's a lot of flexibility in jobs and in work-life balance. And one of the major things is that you don't mind being behind the scenes. So one of the things that makes radiology different is that you aren't really seen by the patient as their doctor for most things. When you are doing procedures or treating them, they will see you that way. But for the most part, you are giving them care without them necessarily knowing who you are. And if you're interested in many different fields, which I was, it's a really good reason to choose radiology because you learn about every single system in the body and how each different specialty might view that system. So like I have to know about surgical, different surgeries, what it looks like. I've got to know all the different cancers that can occur, trauma. So it's really a diverse field. So I'll go through the paths in radiology quickly. This is directed at the med students or people possibly interested in radiology. So you start in medical school. Everyone, whether DR, IR, or ESIR, which is early specialization in IR, has to go through a prelim year, and this is your PGY1. And this can be in transitional year, in medicine, or in surgery. Then you either go to DR or an IR-DR program. For IR-DR programs, it's a 5-year program after the first year. So you'll end up, your graduation year will be PGY6. The first 3 years are predominantly DR, and the second 2 years are predominantly IR. And then after you graduate, you'll become an attending in 6 years. If you go the DR path, it'll be a 4-year residency after prelim, and that's PGY2 through 5. The 4th year is generally pretty flexible. So you can choose to do it in different fields within DR. There's also something called ESIR, which is early specialization in IR, which is a path from DR into IR. And so in that case, your 4th year will be mostly IR. And if you do ESIR, you will do a fellowship. Most people will do a fellowship in IR, which is only 1 year. So you end up as an attending in 6 years, similar to someone who went IR-DR directly. Otherwise, you may choose to do a fellowship after DR residency. Most of them are 1 year, but some are 2, and some are even more than that. But predominantly, you'll be an attending in 6 years as well. And there's some exceptions. You also can choose to not do a fellowship at all. So this is actually becoming more and more popular as the job market is super hot. And in that case, you can be an attending in 5 years. And you're not necessarily restricted on what you can read, but it's kind of what you're comfortable with. But some certain places like academic centers may want you to have a specialty in something if you're going to read it. So this is a very busy slide, but I just wanted to show you all the different diverse jobs that you can get in radiology. And this is non-exhaustive. So these are just examples of them. But as you can see, all of them kind of range from having everything except IR will have some form of diagnostics with it. Meaning you're interpreting scans. But every field also has its own ways to have patient contact and to incorporate procedures. For example, in musculoskeletal, you might be doing joint injections, biopsies, or other procedures, and you'll be seeing patients. So again, this is not exhaustive. I think one of the big draws to radiology is that you can make it, it's really flexible and you can kind of make what you want from it. And especially now, like I mentioned, the job market is pretty hot. So people have been able to, tailor their own jobs to whatever they're interested in. So now I'm going to move on to a radiology primer for non-radiologists. So the goal here is for all of you to understand our DR workflow and how you can help us help you, so we can all treat our patients in the best way possible. So if there's only one takeaway point that you get from my part of today's talk, it's that a specific history in question can go a long way. It is probably the most helpful thing you can do for radiologists, for diagnostic radiologists anyway. So I'm going to just walk you through what happens when a radiologist opens a study. This is an example for myself, but everyone might do it a little bit differently, but have the same steps. So I'll open the study. I'll quickly skim it to kind of get an idea of what we're looking at, if it's like a disaster or not a disaster, something really acute. I'll read the given history, and this is where you guys come in because it's really what you've written as the indication for the exam. Most of the time, I will have to check the chart for more history because I want a little bit more background on the patient that I'm looking at. And then I'll go back and read the study with the question in mind and dictate the report while that's going on. And as I'm reading the study, I'm going through a full search pattern, which is basically a systematic way to look through all the different structures, all the anatomy in a film, which is not necessarily what you've asked for, but all the other stuff as well, because we are responsible for everything that is on the image. Here's also where priors may come in. If the patient has a ton of priors, we may be looking at that for any changes in the interval. If I find any emergent findings, I'll be calling you about them. And then I'll do a quick proofread and finish the report. So everybody kind of does this in their own way. While this is happening, phone calls are also going to be sprinkled in typically. The reading rooms can get super busy from people asking questions, especially during the day when the hospital is busy. So some examples, a technologist might call me and ask if I could protocol the study, which is basically to tell them how I want them to do the study. Someone from the team may call and ask what's the best study to order. In these cases, how you can help us is by having a specific history in mind. So that means when the tech asks me to protocol it, I can quickly look at your indication and know immediately what kind of study I would want them to do. And the same thing with what's the best study to order, I'll know immediately or be able to recommend better what the best scan to do is. And I'll talk about this a little bit more in the next slide. In terms of the team can also call and ask for a wet read in an unstable patient, or sometimes, I get a request for expediting an ED report so the patient can get discharged. These are generally acceptable and pretty reasonable requests as well, especially the unstable patient who wants a wet read. We'll definitely want to help you see what's going on with that patient as soon as possible. How you can make our lives easier is if you have an accession number or an MRN on hand. We do prefer generally the accession numbers because that's kind of like an MRN for the study. So we can go to the study directly rather than the patient's chart and then have to ask which study. For the second point, which is to expedite a discharge, we will read more emergent scans first, but we will happily take the patient information and try to get to it as soon as we can. Another typical phone call we might get is when will my patient get their scan? So this is actually not an appropriate thing to talk to the reading room about in most places because technologists are the ones that generally control the schedule for the scanner. They know, if there's a trauma coming down, that's going to push it back. So try not to call us for that purpose because we'll just direct you to the technologists. So a little bit more on history. So how to be specific. Pain is a really common reason for exam, and it's honestly not great because I don't know if it's acute, chronic, if they had trauma, or where exactly the pain is. Maybe you'll say right hand pain, which is better, but I still don't know if I'm looking at joints, if it's post-trauma, are you looking for a fracture? An example of a really great one is concern for inflammatory arthritis in a patient with lupus-related skin rashes but diffuse joint pain. This tells me exactly the history that I need to know, exactly what you're looking for, and I know that I want to focus on the joints and possibly inflammatory joint disease. This is another example of a great indication where I know that the patient is post-op and you're looking for a bowel obstruction. Even better, you could add what kind of operation they had. That would also help me. But in general, that's a good indication. When looking for stroke, saying neurodeficit acute stroke suspected, that helps me. It tells me that it's urgent and I should get to that as soon as possible. And then if you write ataxia, right leg weakness, it tells me exactly where in the brain I'm suspecting the stroke. I'll still look at everything, but I'm going to take extra care for that area. Another example is malignancy evaluation for stroke workup. So I like this indication as well because it tells me that it tells me relevant history. So this patient had a stroke and you're looking for some sort of malignancy. In this case, I can totally tailor my exam to answer your question. So in the impression, I'll write something like no evidence of malignancy instead of like no acute trauma or something like that that's not relevant. In terms of phone calls, in terms of the search pattern, because we are responsible for everything in the images, I would ask all the clinicians to be mindful with their ordering, because we do have to look at everything in the image. If you order a larger body part than you need to answer your question, for example, we're going to be on the hook for all of that, and it's going to take us longer to read that study. Ask yourself, is it really necessary for the scan to be done inpatient or stat? Will it change the management, or if this pan scan is indicated? And sometimes it is, like for trauma, pan scan can totally be indicated, but it's just an extra step to help us get to the important scans faster. So a common additional phone call we would often get is, what is the pre-medication for iodinated contrast? So you might ask, my patient has a contrast allergy, can they still get a CT scan with contrast? So just a side note here, CT contrast is not the same thing as MRI contrast, and I'll be talking about CT contrast specifically. Things that we will ask you is, what kind of reaction did they have? Was it a physiologic reaction or an allergic type reaction? And we'll also ask about the severity of the reaction, if it was mild, moderate, or severe. And so I'm not going to go through all of these, but the ACR manual on contrast media has a very comprehensive review of all the different kinds of reactions and reasons why you would or would not give contrast to a patient, safety-wise. So for example, in the mild category, allergic-like reactions would be stuff that you think about when you think about allergies. So hives, itching, runny nose, watery eyes, that kind of thing. And physiologic would be a reaction that's not necessarily allergic, but could happen after getting contrast media. So this could be something like nausea or flushing, dizziness, vasovagal reaction. These are all very common. Just to show you an example of severe reactions, allergic-like would be exactly what you're thinking about, anaphylactic shock. Physiologic might be something like hypertensive emergency or a vasovagal reaction that's difficult to treat. So once we know, so I'm going to go through a few different types of reactions, and we'll talk about them in this context. So in AKI, this is not an allergic type reaction. So this patient still can get contrast, but you may consider hydration for this patient. In terms of nausea, this is also a physiologic reaction, so they can get contrast without getting the special prep, which I'll talk about. Hives and itching would be a mild allergic-like reaction, so they can get contrast with prep. Anaphylaxis would be a severe allergic-like reaction. So these patients in general should not get contrast unless absolutely necessary, because the risk of dying from anaphylaxis and laryngeal edema is maybe higher than having to have the scan with contrast. And in the few cases that we have done this in the hospital, at least at my institution, we usually recommend having anesthesia on board just in case, to make sure the airway is secure. So what did I mean by prep? So pre-medication regimens. So this is a steroid prep, and it's used to try to mitigate the allergic reaction that can come from contrast media. So in terms of just in general, for an outpatient, PO method is preferred, and you need, this usually starts 12 to 13 hours before the scan to be effective. In the inpatient or emergent setting, we will use IV steroid prep, but you need a minimum of 4 to 5 hours before it's shown to be effective. This is just an example of a pre-medication regimen, which I've taken from the ACR manual on contrast media. Again, a plug for that. But you really want to just check your hospital's specific policies, because every hospital will have a contrast policy and they may have a preferred method of pre-medication. So takeaways for this part, radiologists are going to try to help you as best we can, and usually we are working as fast as we can. If there's any sort of question, don't hesitate to call us, but keep some of the stuff I've mentioned in mind. And we love to write clinically correlate, but we also love to clinically correlate with you when we have time. So if you do have a question about a scan or something's not making sense, call us and we'd be happy to discuss it. So with that, I'm going to move to the basics of chest radiographs. So again, I've kind of tailored this to cover some of the really basics for med students, non-radiologists, and then also for pre-radiology residents. So for the pre-radiology residents, you guys are going to learn so much about these, like way more than you've ever needed to know, except you do need to know that for your job. So don't worry too much about the details, about studying too much beforehand. This is just going to be something to start you off. So before we talk about interpretation of X-rays, we have to know how they're taken. So these are all pictures of patients getting X-rays. For the frontal view that you are all pretty used to, there's two methods of doing it. There's either an AP, which is anterior posterior, or PA, which is posterior anterior. And so what that has to do with is how the X-ray is taken in relation to the patient. So an X-ray is basically the machine is basically going to have an X-ray source, which shoots X-ray beams towards the patient. The beams will go through the patient at varying, depths and speeds, and then it will be picked up by this X-ray film on the other side of the patient, which will then be turned into the X-ray. So in an AP, which is anterior posterior, that's up here and then also over here, the X-rays will go through the anterior part of the patient first and then the posterior second, and that's why it's called AP. For a PA, which is over here, the X-rays will go through the posterior part and then the anterior part before hitting the X-ray film, and that's what makes it a PA, posterior anterior. And we're going to come back to some of the differences in a few slides, but you can see from this diagram that depending on which orientation it is, the heart, which is indicated here, might look a little bit different in relation to the rest of the thorax. If it's slightly farther away, like in the AP dimension, then it might look magnified compared to the PA, and we'll come back to that. The other method is a lateral, and this often accompanies a PA, so the patient will be standing lateral to the X-rays. And then the other type is a portable. So these other methods are usually done excluding AP. So PA and lateral are usually done in the radiology department because they have this large machine and the patient will have to go down there, stand up for it. But the other method of doing it for patients who are too sick or on the floors is a portable. So that's this picture here. You can bring it straight to the bed so the patient doesn't need to be moved. But you kind of have you're forced to do it in an AP position. So you're forced to do it this way because the patient's laying in bed. You'll put the film behind the patient and then shoot X-rays from here. And the distance between the patient and the X-ray tube is usually shorter than when you take them down to the department. So that can cause even more magnification. And as you can see, the patient is usually laying down, so supine, or they might be able to prop them up a little bit. And that would be a semi-erect, or if they're able to, fully sit up, it could be an erect film. So here's an example of a normal PA and lateral X-ray. So I'm going to go through the anatomy really quick. So there's a lot of anatomy here, but I'm going to try to go through some of the more important ones to get you oriented. So we have the trachea here on the PA, the aortic knob, main pulmonary artery, just one side of it, the left atrial appendage, the left ventricle, the right atrium, and hemidiaphragms. Then we also have the bilateral hilum. So the left one is over here and the right one's over here behind these labels. And some of the smaller pulmonary arteries are also seen here in the shadows. We also have bones. So the first rib is outlined here and second rib here. And as you can see, the posterior ones are much easier to see. Like these are all posterior ribs. As they become anterior, they're a little bit harder to see. And then I'll also point out the scapula here because sometimes with the overlapping scapula, you can see it kind of makes it wider here and it could look like something, could look like pathology if you don't realize that it's the scapula. On the lateral, we have the ascending aorta here and it's going to go back this way. Here's the trachea in side view, left atrium, left ventricle, which are both going to be more posterior. And then we have the two hemidiaphragms. One other thing I'll point out on the lateral is something called the spine sign. So normally the spine should be getting darker as we go more inferior. And one thing that we talk about in radiology is a positive spine sign. And that's when it's not actually it's not becoming darker as you get more inferior. And that tells you that there's something going on here. So I'm going to go over a few more basic concepts to keep in your toolbox for chest x-rays. So the first concept is that radiographs tell you about densities. The second is that patient positioning and the patient breath that they take can change everything. I'll talk about the silhouette sign briefly and then search patterns. So first, density. X-rays are generally able to show you about 4 densities. air, soft tissue or water, which looks similar, bone, or metal. So air would be like in the lung, it's pretty dark. Soft tissue or water, it'll look something like this. So this is the soft tissue of the chest wall. This is the diaphragm with some of the liver underneath it. So it's kind of this middle density. Bone is going to be more dense if you think about it. They're much, it's a much more dense structure compared to soft tissue. So it's going to be even brighter. And this is an example in the spine. And then metal is going to be the most dense. So it's going to be the brightest. And these are just examples of buttons on a patient's gown overlying them. The second concept is that patient positioning can change everything. So whether the patient is AP or PA, which I alluded to earlier, it can make things look super different. So these two images are actually of the same patient. This one on the left is an AP image, which was taken mobile, which is also a synonym for portable. And then this image on the side was taken PA. So you can see that on this side, the heart looks kind of wide. And one of the, if you compare it to the chest wall width, one of the kind of shorthand rules we use is that if the cardiac width is greater than 50% of the thoracic width, you may be looking at an enlarged heart, maybe cardiomegaly. But one thing to keep in mind is that the position will change this. So if you look onto the right side, the heart and mediastinum actually look great. And again, this is the same patient, just taken AP versus PA. So you have to be super careful when you are commenting on the heart size, especially on a portable and if it's AP. And that's just something to keep in mind. And again, to remind you, the portables are usually for the inpatients, and it can be taken with this mobile X-ray machine, and they're often laying down or supine in bed. And this is just to bring it back to the first image about how X-rays are taken when you are PA versus AP. So things can change with the heart. If you are PA, then the heart is closer to the X-ray film and will look smaller compared to AP when the heart is slightly farther away from the X-ray film. So you have to be careful. The other thing about patient positioning is that rotation can change everything. So on the left here, I'm going to show you, this is a pretty well-centered radiograph. So you have the trachea there. You have the two clavicles that are coming in, and the trachea looks pretty centered within them. And then you have the spinous processes of the spine over here, and they're kind of, right in the middle of the trachea as well. So everything is kind of centered. Compare that to the image on the right, where the trachea is kind of off to the side. The clavicles are looking a little bit off center too. And then when you look at the spinous processes, they're not overlying the trachea like they should be. And you can see that it's really changing the way that the contour of the heart looks as well. It's looking like it's shifted this way, even though it may actually be closer to the left side, which is where it usually is. And this is really common also in ICU inpatient portable techniques, because sometimes the patient's lying in bed and they can't get straight. The other thing I want to show you was, how much of a difference the patient breath can make. So, usually in a fairly healthy patient, if they're just getting like a screening X-ray or something and they come down to the department, they'll be able to take a big breath when we direct them to hold it. And then when we take the picture, it'll be mostly filled, the lungs will be mostly filled with air. But when patients are sicker, they may be short of breath. They may not be able to inhale as much. They may not be able to hold their breath. And then the other case is that we may not be able to take the image at the right time when they're holding their breath. And that can change everything. So what I want to show you is on the left side, there's a patient these are the same patient. On the left side, they're kind of mid-expiration. And then on the right side, they're more in inspiration. And you can see that the lung fields look super different. So just to show you, I've drawn a line through this lung field to see how tall it is. And on this side, and if you compare them, you can see that this side, they're not taking as deep as a breath. And because of that, there's more opacity in both of the lung fields. It looks a little bit hazy compared to this side, which looks more lucent. Again, this is also common in ICU and inpatient portable technique because patients are sicker, and also the positioning can be a little bit more difficult. So the third thing I want to talk about is the silhouette sign. This is really fundamental to understanding how radiographs work. And the definition is basically that the normal silhouette of a structure is lost. We call that the silhouette sign. And this happens when similar densities border each other and they blur out a normal outline into one shadow. So in this case, in the first image, there is an opacity that's posterior to the heart. It is a similar density, but because it's posterior to it and not bordering it, you can still see two distinct outlines. In the second image, the lung opacity is right next to the left heart border. And this causes the normal left heart border to be blurred out. And this is the silhouette sign. So because it's right next to it, it becomes one shadow. And this image is from a website called Radiology Assistant, and that's just a plug for this website because they have really great informational radiology articles. The last thing is a search pattern. So this is super important for future radiologists. Everybody kind of has a different search pattern. It's tailored to your own personal preference. But as long as you look at everything, you follow this search pattern and you stay consistent, it doesn't really matter which order you do it in. This just helps you look at every single structure and make sure you're not missing anything. For non-radiologists, you may have been taught this already, but there's the ABCDE method of making sure that you cover everything. So there's these all stand for different reminders to look at different structures. So airway, bones, the cardiac or mediastinal border, the diaphragms, and then everything else. All right, so now we're going to go through some cases with the last part of my talk. So I'll kind of give I won't give you the diagnosis immediately, but I'll talk through the findings. And for the sake of time, I'll just kind of go through it all, but the diagnosis will be given towards the end. So you can kind of think to yourself, what you might be seeing. And just a plug for Radiopedia, which is another awesome radiology resource. It's kind of like Wikipedia, but for radiology findings. All right, so this is our first one. So let's see. So we have a PA and lateral X-ray. So you might be looking at, and I'm going to show you these normals here on the side for reference. So you might be looking at that part, and at the right lung base, you're saying, there's something there. And then when you look at the lateral, there seems to be this extra opacity over here as well. So I'm just going to extend this line up and point out some structures. So this is going to be the major fissure on the right, and this is going to be the minor fissure. And that's going to be the right upper lobe, right lower lobe, and right middle lobe. So it looks like there's something filling the right middle lobe. It's, more opaque than it should be. And then on this side, it's not that well appreciated, but kind of the right heart border is not that well seen. So this is actually a silhouette sign that something is touching it. So this is an example of pneumonia with a silhouette sign. For this next set, here's your normals. This one is a little bit more subtle, but you might be looking at the heart and thinking that it's a little too dense. Maybe there's something behind it because normally you'd be seeing more of the lung behind it. It's a little bit more lucent. Maybe you're seeing some vessels, and it's pretty hard to tell what's going on back here. And then when you look at the lateral, what do we got here? We have the spine sign. So usually the spine should be getting darker as you go more inferiorly, but here there's kind of something there that's abnormal. And so I'll just point out the anatomy for the left side. This is the major fissure, and it's going to be the left upper lobe here and left lower lobe. So it looks like there might be something in the left lower lobe. And this is a pneumonia in the left lower lobe with a spine sign. All right, for this example, this is pretty subtle. So maybe there's a little bit of asymmetry here. It's looking a little bit more opaque than the other side. And then when you look at the lateral, you notice this extra density here again. So this is actually an example of atelectasis, and this is again in the right middle lobe. And one thing that you probably have already noticed when we read chest X-rays is that we'll say a lot of, we might hedge a lot about atelectasis or pneumonia, and I'll just show you why. So this is a very classic case where we can distinguish between the two, but they're both going to be opacities. So on the left side, we have pneumonia, and on the right side, we have atelectasis, both cases that I showed you earlier. So pneumonia, atelectasis. One thing you'll notice is that pneumonia tends to have a larger volume compared to atelectasis, which is kind of more flat with decreased volume. And that's because atelectasis is just collapse of the alveoli for whatever reason. It can happen both normally in expiration, and it can happen due to pathologic reasons. In general, for pneumonia, that the alveoli might be filled with, edema or pus. So you're going to expect at least a normal volume, if not increased volume of the lobe. All right, so now we have two radiographs. These are two different patients, but a similar concept. So you probably have noticed that there's a lot of busyness in both of them. And so I'm gonna show you, just zoom in and show you some of the findings. Here we have a lot of extra lines. So these seem to go all the way to the periphery, which is not normal. And these are your curly B lines. On the right side, we see, again, these abnormal lines, which are curly B lines, but then we also see an opacity next to the hilum. So we call this perihilar. And it's kind of like a fluffy opacity, but really you could just call it an opacity. And this is an example of pulmonary interstitial or alveolar edema. So the curly B lines are demonstrating fluid within the pulmonary lobules, and that's going to be pulmonary interstitial edema. Once it becomes, so overloaded that the edema is going into the alveoli, it'll become alveolar edema, and it'll be more like a generalized opacity rather than, straight lines. And here's another example. So as you can see, there's some perihilar opacities on both sides, and they're kind of in what we call a batwing configuration of perihilar opacities. And that's a typical way to describe pulmonary alveolar edema and a typical pattern you might see it in. All right, so here we have two radiographs from the same patient. And something is looking super weird in the right lung field. So it's looking a little too lucent. There's no lung markings that you would see on the other side. The trachea is looking a little bit off center as well. It's kind of bowing towards the opposite side as the lucency. And the mediastinum in general looks like it's kind of shifted to the opposite side of the lucency. So this is an example of a tension pneumothorax. So the lucency is going to be your pneumothorax. So that's when air gets into the pleural space. And if it's really bad, like in this case, it'll compress the lung over, and you won't see any of the normal markings that are shown in the lung. One thing you want to really look for when there is a pneumothorax is evidence of tension. And tension just means that there's air getting in, but not enough air getting out, so that it just becomes more progressively filled with air, and it pushes all the other stuff in the thorax to the other side. And that's what we're seeing here. So on the right side, it's the same patient, and they've put in a chest tube here. And so you can see that the trachea looks a little bit more centered, actually. And it looks like the shift of the mediastinum has slightly corrected. So it's looking more like it's in the center, or where it's supposed to be, slightly to the left rather than extremely to the left. And here you see that the border is, the right side of the mediastinal border is now not so pushed over either. And so that's, the treatment for a tension pneumothorax is to put in a chest tube and relieve that pressure, allow the air to escape, so that it's not pushing so much on the mediastinum. But you can see that the pneumothorax is still there. It hasn't completely resolved yet. It's still very lucent on the side, and this is the compressed lung actually here. And this is just another example. So again, you'll see lucency here. There's no markings past this line, and there's this thin line here. And so this is an example of a pneumothorax that's not as large, just to show you an example. And in this case, there's no shift of the mediastinum, so there's no evidence of tension either. So one common, thing that comes up, especially for non-radiologists or for radiologists just starting out, is that a pneumothorax or is that a skin fold? So a skin fold is a really common mimicker of pneumothorax. And so I'm going to show you, blow this up and show you that for a pneumothorax, you're going to have this really thin line, and you're going to have no markings past this line because the lung is all on this side. you're going to have a thin line which is outlined on both sides. It's like pencil thin. And on this side, I'm going to show you a skin fold. So here's the line that I'm showing you. And it's hard to appreciate, but there are still some lung markings past this line. It's also showing a gradient density. So instead of this thin line with kind of dark on each side, this line shows a sort of density. It's slowly getting from brighter to darker. And that's the giveaway for it being a skin fold rather than a pneumothorax. Another thing you can look for, this one doesn't show it, but the line may extend past the lung and into the soft tissue. And that tells you that it's a skin fold because there's no lung out there. All right, so here's another example. So what we have here is there's asymmetry in the diaphragms. So it looks like there's too much lucency overlying this right-sided costophrenic angle, which is what we call this area. And this is what we call a deep sulcus sign, which is also a sign of pneumothorax. But in this case, it's for a patient who is laying down supine. And to kind of show you how that works, so comparing a pneumothorax in the erect position versus supine position. So when a patient is upright, the air is non-dependent and it's going to collect at the highest part of the pleural space. So that's why in the previous films, we kind of saw it collecting here. But when a patient is laying down, the highest part of the lung is actually the base. And so that's why we're seeing the lucency over here when the patient is laying down. And then I also wanted to point out here, while we're here, because there's another finding, and some of you may have seen this, but if you trace the ribs out on the right side, they're kind of looking a little disconnected, like they're not really going anywhere, and it doesn't seem to connect to this rib. And if you compare to the other side, they're all a continuous line. So these are actually rib fractures. And as you can see, they could be very hard to tell, especially if they're not very displaced. Maybe you'll just see like a lucent line here, and that can be really difficult. The other things I'll point out, so there's an endotracheal tube, there's a chest tube in this patient, there's also an NG or OG tube, and there's also surgical packing. And these are all things that you will eventually learn once you see them over and over again. And so I'll just point them out since they're here. All right, for this one, I'll show you your normals. And it looks like there's something going on here at the right costophrenic angle. So instead of this normal contour where it goes straight down like that with a sharp angle, you're seeing that there's no angle here of lucency. Instead, there's what looks like some sort of layering opacity there. And on the lateral, instead of this sharp angle as well, you're seeing it's a little bit blunted here. So this is an example of a pleural effusion, and this patient is upright, so it's layering at the bottom. Just in general, for your information, for a frontal radiograph, you may need upwards of 200 cc's of fluid before you can really see it with definitive confidence. And on a lateral, you can see it with as little as 50 cc's of fluid. All right, so here's another example. And you probably noticed that the left lung field looks diffusely kind of hazy compared to the right side. And this is an example of a pleural effusion while supine. So the previous one, they were upright, and this one, they're laying down. And so if we think about our pneumothorax diagrams that I showed before, air is non-dependent, will rise to the top. But fluid is actually dependent and will sink to the bottom. So it's kind of the opposite of how a pneumothorax would be. So when the patient is upright, like we saw earlier, the pleural effusion will be at the bases. But when they're supine, the pleural effusion is going to layer at the bottom and kind of create this hazy opacity. And that's what we're seeing right here. I'll just point out some lines and tubes again while we're here. So there's an endotracheal tube, there's a feeding tube and an NG-OG tube. The thinner line here that ends here is the NG-OG, and the thicker one is the feeding tube. There's a right-sided PICC line here, and then there's right and left IJ lines that are going centrally. Here's another example. I think the finding is pretty obvious that the left side is completely whited out. And I'll just show you that one day prior, this patient actually had a fairly clear lung considering. So there's complete whiteout of the left lung. So, what could that be? Maybe it's fluid, maybe it's a huge consolidation. We're not sure. But if you take a look at the trachea on the prior when it was relatively normal, you can pick out the outline pretty well. But on today's, it kind of has an abrupt cutoff here. Like you can't see the rest of the left bronchus. And then the right side of the cardiomediastinal silhouette is seen here. But on this one, it's kind of hard to see, and maybe it's shifted over a little bit to the left side. So that kind of tells us that there's loss of volume, and maybe there's something blocking the left airway, which is why we can't see the more distal portions of it. And so this is an example of mucus plugging. Keys to making this diagnosis is timing and looking for changes in volume. So a pneumonia usually doesn't develop this quickly, or pleural fluid typically won't accumulate this quickly unless in extreme circumstances. So this being one day prior, or sometimes it's only a few hours prior that it was normal, that might be your tip off to think about mucus plugging. The other thing is volume. So when there's mucus plugging, you're basically blocking off the airway so air can get through. So the rest of the lung will have complete atelectasis or volume loss. And that means that, the mediastinum might shift this way because there's less volume on the side. And for a pleural effusion, you would expect increased volume because there's a lot of extra fluid there. So you wouldn't expect the mediastinum to shift that way. All right, here's another case. So in this case, it's a pretty subtle finding in the mediastinum, but you might have noticed all this other stuff. So the mediastinal finding is this thin line here with lucency on this side. And it kind of goes around all the way if you keep looking for it. And then the other finding is that there's air here in the subcutaneous tissues. And as I mentioned before, there's a ton of it here. So there's too much lucency around the heart. There's this, what we call a continuous diaphragm sign with lucency above the diaphragm all the way across. And there's subcutaneous emphysema. So this is an example of pneumomediastinum. These findings can be super subtle. So you have to be looking for them. So you want to make that part of your search pattern. So those are all the radiographs I have for you today. So takeaway points for this part: radiology is a diverse field that you can tailor to your interests. We can help you the most when you provide specific histories and questions. Contrast pre-medication is for allergic-like reactions only and will need a minimum of 4 to 5 hours in the emergent setting or 12 to 13 hours to be effective. For chest x-rays, pick a search pattern and stick to it. Consistency is key. And the more cases that you see, the more your skills will improve. So hopefully I've kind of started you out on that journey, and you can check out some of the websites that I mentioned to see a ton of more cases. And that's all I have for part 1. Thanks for listening, guys, and sorry for the technical difficulties.
Thank you, Bianca. We'll now take our intermission.
All right, everyone, welcome back. So I'm going to talk about the abdomen and head. It's going to be a pretty quick whirlwind tour. So let's get started. All right, so first to talk about the abdomen, we'll just touch on a few things, which include radiographs, small bowel follow-throughs, and a little bit about CT. So the first point we'll talk about, which Bianca kind of alluded to on chest x-rays as well, is patient positioning. So there are three basic ways that we can obtain x-rays in the abdomen. The first is upright, where the patient's either standing or sitting up. You can see the x-ray tube in front of the patient, so it's from front to back. There's a supine film in which the patient is laying on their back, usually in patients who can't stand up or who are too sick. Again, the x-ray tube is in front, and the x-rays go from forward to back. And then finally, there's left lateral decubitus or right lateral decubitus, but basically the patient's laying on their side. And again, the x-ray tube is in front, so the x-rays go from front to back. So these have different implications for pathology, which we'll talk about in a little bit. Okay, so just like Bianca said about chest x-rays, it's very important to have a systematic approach in anything you do in radiology. So here's just a mnemonic that can be useful for how to look through abdominal radiographs. So the mnemonic is ABDOX, ABDOX. And so A is air, B is bowel position, D is dense structures like calcifications or bones, O is for organs and soft tissues, and X is for external objects. I generally use this pattern, which is a little bit more simplified. So usually I look for lines and tubes that are in place, make sure I clear those off. I look at all the dark stuff, so that's the gas, and look for free air. And then I look at all the bright stuff, that's the bones and calcifications, and then I just look at everything else. So, if you look at these a lot, you'll start getting a system and a pattern. It's just important to be systematic and to make sure you use the same pattern every time. So abdominal radiographs are really only good for a few things. So we'll touch on some of those things now. Really lines and tubes, foreign bodies, obvious pathology, and then small bowel follow-throughs. So talking about enteric tubes, there are two basic types or a few different types. The big two are this Salem sump, which is basically like a suction tube. And then the Dopphoff or the feeding tubes, where you're trying to, give medication or give other things through the tube. So this has implications on the X-ray. On an X-ray, so the tubes look like this thin white line. And you can see over here on the left image, this is an NG tube or a suction tube. And you can tell that because there is a little gap in the radiodense marker. And that tells you where the most proximal side hole is. So there's other holes towards the distal end of this tip, but this is the most proximal portion. So the key question about where the location of this enteric tube is where is this proximal side hole? That's in comparison to this feeding tube or the Dopphoff tube, in which this does not have side holes along its course. It just has this tip at the end. So the main question to ask yourself for these types of tubes is where is the tip? Where is the tip located? So in general, the location of your enteric tubes, it should go down the midline in your chest. It crosses the GE junction, and then, your stomach sits in the left upper quadrant, so your tube should take some portion in the left upper quadrant. There are different places that people want their enteric tubes to be. If you want your enteric tube to be prepyloric or in the stomach, you want it to stay in the left upper quadrant, but the tips should still be beyond the GE junction. You can also have a post-pyloric location. So here you can see this tube here. It courses into the left upper quadrant, and then it crosses midline. It spends some time in the right upper quadrant, and then it crosses back towards the left side. So that's the expected course for a post-pyloric enteric tube, where you can see that it's passing the GE junction. It spends some time in the left upper quadrant in the stomach. It crosses midline because that's what your stomach does. And then your duodenum or your peripyloric region is about right here. And then, it follows the course of what you expect the duodenum to do. Of note, this person also has an enteric tube that's in the stomach here. Okay, so a very common question that we get is where is this enteric tube and can I use it? You'll notice that oftentimes in our reports, the wording will be something like the tip projects over the stomach. And that's because we can confirm where the tip is located radiographically, but we're not really sure whether it's working. So we can tell you that it looks like the tip is in the stomach, but I can't tell whether the tube is functioning, like whether you can aspirate or flush through it. And so we very frequently don't like to say, yes, you can use it. We'll usually just tell you the location. And if that's where you want the location to be and it seems to be working clinically, then you can use it. Okay, so just some practice cases here for the location of these enteric tubes. So this is an example here where you can see the radiodense marker. There's a gap in this marker. So this is a suction tube, and then the tip of it is here. You can see that the entire course of this is above the GE junction. So this means that the side hole of this enteric tube is in the mid-esophagus. Remember, the esophagus is a little bit to the left of midline here. Okay, here's another example. So this enteric tube, it looks like it's coming down into the esophagus. That's okay. And then all of a sudden it takes a loop back upwards and it terminates here in the upper chest. So this is an example of an enteric tube that's going down into the esophagus, but then it loops back on itself and it terminates in the upper esophagus. Not ideal positioning usually. Okay, and then this is one final case. So here you can see this feeding tube. It enters into it enters into midline here. And then all of a sudden it takes this course. Instead of staying midline, it comes off to the right, and then it twirls back over and it terminates here in the left chest. So this is an example of a feeding tube that has been placed into the trachea or into the airway. And it takes a little loop off in the right main bronchus before it enters into the left lower lobe bronchus and terminates there. So again, definitely important to not feed this patient because then you will just be feeding their lung, which is usually not recommended. Okay, moving on to some other key findings. So these is just a smattering of cases to ask to get some pathology. So what's the most likely diagnosis in this case? So you can see that there's an enteric tube here. It looks like it's terminating in the left upper quadrant, but then there's also this finding here in the right lower quadrant. It looks radiodense. This is actually a retained foreign body. This is a lap sponge. This blue part of the sponge is actually made radiodense by the manufacturer so that we can find it on an X-ray. So this blue marker corresponds to this opacity you're seeing in the right lower quadrant. Okay, here's just a fun case of a swallowed foreign body. So here you can see this person. This was not external to the patient. This patient had swallowed their AirPods here. Okay, what's the most likely diagnosis in this case? Okay, this is an example. This is a patient who's laying on their back or a baby who's laying on their back. This is them turned onto their side. And now you can really see that there's all this darkness here. You can see this darkness on the left side of the abdomen that you can't see as well here because this patient was laying on their back. So this is an example of pneumoperitoneum or free air. Notice how, just like Bianca was talking about air rising non-dependently, you can see that air is going to go to wherever if the patient's laying on their side here, it's going to rise non-dependently. It goes to their left side because this is the side that's up on the patient. Whereas when the patient's laying on their back, air is going to go more anterior or towards the front part of their stomach. This is just a couple other images to show you that concept. So really the most important thing when you're trying to identify free air is to think about how the patient was positioned. In this case, the patient is positioned upright or erect. And so one of the common signs you can see is this continuous diaphragm sign. You see some air underneath your diaphragm outlining it. So you can see the entire diaphragm, which you don't normally see. In this example, this patient is supine, and so all the air is going to rise non-dependent or anterior in the patient. And so this is an example of the football sign where the seams, these seams here, that's this part here. So this is air outlining the falciform ligament. So this is an example. These are two examples of free air, and they look totally different because the patient is positioned differently. Okay, another finding that we can sometimes see on X-ray is small bowel obstruction versus ileus. So in general, there's this guideline of the 369 rule, which is that small bowel loops should not be more than 3 centimeters. Colon should not be more than 6 centimeters, and cecum and rectum can get up to 9 centimeters. Again, those are general guidelines. They're not hard and fast rule. But they help us to identify whether we think a bowel loop might be distended. So these are two different pathologies. This one on the left is a small bowel obstruction, and this one on the right is ileus. The major findings that we look for on an X-ray in a small bowel obstruction, we're looking for these central dilated small bowel loops, whereas in an ileus, you generally have this more diffuse gaseous distension of both small bowel and colon. So this is one of if we see these two images, that helps us really identify small bowel obstruction versus ileus pretty nicely. Another finding you can see in SBO that people talk about is that you have these shorter air fluid levels at multiple levels. And that's in comparison to an ileus in which you see these longer air fluid levels. This is not, I haven't really found this sign that useful, but it's something that you'll see if you read about this. But in general, it is really important to know that SBO is actually very hard for us to identify on a radiograph. So radiographs are only about 50 to 60% sensitive for SBO, and it can be really hard for us to tell the difference between the two. So getting back to Bianca's point about the clinical history being very important, if the person doesn't have any isn't having any bowel movements, they just had they just had surgery, they have adhesions, that's a sign that might be SBO. Versus if they're taking a lot of morphine, pain medicines, that can be a sign that this is an ileus instead. And if an X-ray doesn't help, when in doubt, you can always send them to the donut of truth or the CT machine to help identify whether it's an SBO or an ileus. Okay, so just to highlight that point again, so this is an abdominal radiograph. The question is whether there's an SBO. You can see a few, bowel loops that have gas in them, but overall, it doesn't look that concerning. This is a CT from the same patient, and you can see that there's all these fluid-filled bowel loops, and this patient did end up having an SBO. So from this X-ray, I would not have been able to diagnose this as an SBO. They got a CT and they were found to have an SBO. So just a case to show that it can be really hard for us to tell on abdominal radiograph. Okay, so those are the three things that we've talked about: foreign bodies, free air, and SBO versus ileus. So moving on to small bowel follow-throughs. Small bowel follow-throughs are generally a way to identify or to see whether an SBO can be cleared or whether the SBO has resolved. It starts with a scout image that gives you a baseline of the patient. The patient usually drinks about 200 to 300 cc's of contrast, of bright contrast. And then you take different KUBs at different time points to see how far the contrast has progressed. So normal small bowel transit is about 30 to 120 minutes. And the presence of contrast in the colon at 24 hours predicts resolution of an SBO with 97% sensitivity and 96% specificity. So it's a pretty good test. So here's just an example of an SPFT. This is the scout image, just to give you a lay of the land to see where all the bright things are. This is an image obtained at 1 hour. So now you can see that there's bright contrast in the patient's stomach, as well as a bunch of small bowel loops, but you do not see any contrast in the colon at the periphery of the abdomen yet. And then this is an image obtained at 5 hours. Now you can see there's again bright contrast in small bowel loops. And then this, on the periphery, you can see that there's also contrast or bright stuff in the colon. So this would be the cecum over here, and then you can even see some contrast in the descending colon as well. So at this point, we would stop the small bowel fall through. We would dictate it as contrast makes it to the colon by the 5-hour time point. Okay, we'll move on to CT abdomen pelvis. So one of the main concepts to take away from this is that CT abdomen is the use of IV contrast. So there are many different phases that we can get in a CT abdomen pelvis. The first is a non-contrast study where you don't have contrast yet. So there's no contrast in the vessels or in the organs. This is often very useful to look for stones or calcified things. And often we use this in patients who have a low GFR who can't tolerate the nephrotoxic contrast. The next phase we'll talk about is a late arterial. So a late arterial where you can see that most of the contrast is concentrated in your arteries, like the aorta here. This is very commonly used to evaluate for a bleed, to look for active extravasation of the contrast. And then you also can use it to evaluate a mass, to see if a mass is arterially enhancing. The next one is portal venous. This is the standard phase we use. So if you just order a CT abdomen pelvis and you get one phase, this is generally the phase we're aiming for. So this is the standard that we generally use. It can also be used to evaluate for a mass if you get different time points. And then the last one is a delayed phase. So this one you're waiting a little bit longer for the contrast to be excreted by the kidneys. So now you can see that most of the contrast is concentrated in the collecting systems. This is very useful, for example, for a ureteral injury to see whether contrast is getting out of the ureters. Can also be used to evaluate a mass. So IV contrast in a CT abdomen pelvis, it's all about timing. It's about when you scan the patient after the bolus of contrast. So you inject contrast, you wait a certain amount of time, and depending on how much time you wait, you'll get these different phases. There's also two different types of PO contrast. So oral contrast that a patient drinks, you can have negative oral contrast, which just means that it's not bright. So that's very commonly used in a study such as an enterography, just to distend bowel loops so that you can see the wall. And then there's also positive oral contrast, and this is often very helpful if you're trying to look for a leak. So if you want to see whether that positive oral contrast makes it outside of the bowel, if it's extraluminal. Okay, reading a CT abdomen pelvis, we definitely do not have time to go through all of this, but again, most important to be systematic. Here's just a resource that's very helpful for looking for abdominal CTs. It's learnabdominal.com. It goes through a whole series, so something to look for, something to look at if you're interested in finding an approach. But we will talk about just a few key findings. So this is an example here of fat stranding. Fat stranding is just this, this ill-defined haziness or increased attenuation in fat that's supposed to be totally dark. Fat stranding is a very non-specific term. It's not really a diagnosis, but it just suggests that there's inflammation and it helps us localize the pathology. So in this example, this is a blind ending tubular structure in the right lower quadrant that's arising from the cecum. This is the appendix that's dilated and it has inflammation around it. So an inflamed appendix or appendicitis. Just a couple more examples of fat stranding. So here again, you can see this ill-defined hazy attenuation in the fat surrounding the gallbladder. So this is an example of cholecystitis. And then here you can see, again, fat stranding as this ill-defined attenuation centered around the pancreas. So this is an example of pancreatitis. Okay, next case or next big topic. This is a question, what should you do next? Okay, and the answer here is that you should stat page vascular. This is an example of a ruptured abdominal aortic aneurysm. So of course, it's very important to make this finding that there's this very large abdominal aorta. But the major point of this case is that there's all of this complex or hyperdense fluid in the peritoneum. So this is the key finding here to show you that it's not just that this patient has an abdominal aortic aneurysm, but this aneurysm has ruptured. And so you really need vascular to see them as soon as possible. Okay, and then just another one final case. Okay, in this case, the answer is to call surgery because this person has free air. So here you can see these little black dots that are outside of bowel. It's actually a little bit easier to see free air in the abdomen when you use a lung window. So that's one of the key takeaways is that if you're looking for free air, use your lung windows in the abdomen. And that's because you can see the black density of the air against all the other white structures. So this is an example of free air. If the patient doesn't have a reason for it, then you should definitely call surgery because maybe they have a perforated viscus. Okay, so these are just some of the key findings we've talked about in the CT. You have fat stranding, an abdominal aortic aneurysm that's ruptured, and then free air. I know this is by no means comprehensive, but we don't have a lot of time, and hopefully this will give you a little sense of what to look for major findings. Okay, we'll move on to neuro. This is something that I feel like as a medical student, we didn't spend much time on, so that's why I wanted to talk about it. Here's just a brief overview of what we'll talk about. So we'll talk about CT, we'll talk about blood, MRI, and then stroke. Okay, so this is just a very basic approach to head CT. Unlike the abdomen, the head doesn't have like discrete organs. Everything's just kind of like a conglomerate together. So it's often very useful to use symmetry. So to compare the right side to the left side to make sure that they look the same, unless the finding is bilateral, in which case you can't use symmetry. But oftentimes symmetry is your friend. It's also important, especially in the head, to use all your planes. So to use axial, coronal, and sagittal. Sometimes things are easiest to see on one plane, for example, in coronal, rather than axial. And then this is just the 4 big points of things we look for on a head CT. So you want to look for blood, you want to look for hydrocephalus or dilated ventricles, so these ventricles here. You want to look for mass effect, so if there's a big mass or big blood area of blood that's pushing on other structures. And then you want to look at the gray-white differentiation to the best degree that you can, knowing that head CTs are not the best at doing this. Okay, so talking about intracranial blood. So these are 2 different cases of intracranial hemorrhage. And I will tell you that this one on the left here, this is a subdural hemorrhage compared to an epidural hemorrhage on the right. So a subdural hemorrhage has this more concave look. It tends to look kind of like banana or a crescent. And then usually it's the result of a bridging vein injury, so a venous injury. There often is no associated calvarial fracture, and it's very commonly seen in older people. So oftentimes seen in an older person who's had a ground level fall, they come in, get a head CT, and this is a pretty common finding. So this is the subdural. This on the right is an epidural. So an epidural, in comparison, has a more convex or lenticular shape. It often is a result of injury to the middle meningeal artery. It often has an associated calvarial fracture, and then patients classically present with this clinical finding of a lucid interval. So they pass out, they come back to consciousness, and then they pass out again. So that's the lucid interval where they're awake for some period of time before they pass out again. So two important findings to differentiate a subdural versus an epidural. These are three other examples of types of intracranial hemorrhage. So here on the most left, we have an intraparenchymal hemorrhage. Most common causes are hypertension. Sometimes it can be due to amyloid. This middle panel is subarachnoid hemorrhage. The classic clinical finding is a thunderclap headache. Most commonly, it's due to either aneurysm or trauma. And the major complications that we look for are hydrocephalus or vasospasm. So blood is quite irritating to arteries, and it can cause your arteries to kind of spaz out a little bit. So that's what vasospasm is. And then this one on the right is intraventricular hemorrhage. Now you can see this bright blood that's inside the ventricles, most commonly from hypertension and aneurysm or extension from a subarachnoid or intraparenchymal hemorrhage. And the major complication to look for is hydrocephalus. So blood can get kind of gummy, and it can block up all of the outflow tracts for CSF. And so you can get dilated ventricles as a result of intraventricular hemorrhage. Okay, so this is just an image to show you the different types of intracranial hemorrhage that we've talked about. Okay, moving on to MRI. So MRI, probably the main thing I'd like you to take away from this is just being able to identify sequences. So we're just going to go through some sequences, and I'll give you, what I usually use to identify them. So this is the first example. You'll notice here that CSF, so in the ventricles, the CSF is dark. CSF is dark, and then the major takeaway from this is that the white matter, which is all this stuff inside or centrally, the white matter is white and the gray matter is gray. So this is an example of a T1 weighted image. T1 is really good for looking at anatomy, and so that's how I usually remember that white is white, gray is gray. So T1 is good for anatomy, white is white, gray is gray, and then CSF is dark. This is another example of a different sequence. So in this case, you can tell now that the CSF is bright, which a lot of people use to identify this sequence. But I want to highlight that what you really should look at is the white and gray matter. So now you can see that in comparison to the T1, now the white matter is darker than the gray matter. So now white is gray and gray is white. So this is an example of a T2 weighted image. So really the key takeaway here, CSF is bright, and then white is gray, gray is white. So it's flipped from what a T1 is. Okay, this is the major reason why you want to look at the white and gray matter to differentiate. Here you can see CSF is dark, so you're thinking, okay, I know a T1 has dark CSF, but you'll notice that the white matter is gray or darker than the gray matter. So now white is gray, gray is white, CSF is dark. This is a flare. So this is a fluid attenuated inversion recovery, which is a type of T2 weighted image with the CSF suppressed. So that's why the CSF looks dark here. Again, the major way to differentiate this from a T1, which is shown here, CSF is dark in both, you'll notice, but the white is white and gray is gray in a T1, and white is gray and gray is white in a flare or a T2 suppressed with CSF suppression. Okay, moving on to the next one. So this is a sagittal image. You'll notice that there are these really bright curvilinear areas all over the brain. So this is a post-contrast T1. If you looked at the white and gray matter, you would see that white was white, gray was gray. But all of these bright areas here, those are vessels that are enhancing with contrast. So vessels are bright. That's a key giveaway that this is a post-contrast scan. And then the other key point to identify is that if you can see the nasal mucosa enhances on contrasted images. So people like to use the nose. So look at the nasal mucosa. This is an example of the post-contrast where the nasal mucosa is enhancing compared to a pre-contrast where the nasal mucosa is not. So this is a giveaway that The vessels are bright. No, nasal mucosa is enhancing. This is a post-contrast T1. Okay, and then these are two images that you look at together. So on the left image here, on both images, you can see that there's pretty crappy resolution. So you really can't see anything outside of the brain itself. So you don't see like all the soft tissues and the bones outside the brain. So crappy resolution is 0.1. And then if you look at the CSF dark on this image, and the CSF is bright here. So these are examples of a diffusion weighted image on the left and an ADC, or apparent diffusion coefficient, on the right. So bad resolution, dark CSF, bright CSF. Okay, both of these, or the DWI is a T2 weighted image, and that is important, which we'll talk about later in being able to differentiate pathology. So DWI is used to look for restricted diffusion, to look for something that's not allowing water to diffuse regularly. If you have something that is restricting diffusion, it will be both bright on DWI and dark on ADC. So you have to confirm that something that's truly restricting diffusion is bright on DWI and dark on ADC. The reason for that is because of this phenomenon. In this case, you have something that is bright on DWI, so you might ask, is that restricting diffusion? But if you look at the ADC, you also note that it's bright on ADC. So this is an example of a phenomenon that we call T2 shine through. And the reason for that is because, remember, I said that a DWI is a T2 weighted sequence. So that means that anything that's bright on T2 will also be bright on DWI. And so that's really the key utility of having the ADC with the DWI, is to make sure that something that you're seeing bright on DWI is not just bright because it's also bright on T2. It actually has to be bright on DWI and dark on ADC in order for it to be true restricted diffusion rather than this phenomenon here. Okay, so this is just practicing. There's several other sequences, but just for time, we'll go through these first few. So this is just some practice cases. So starting with this top left image here, you'll note that CSF is dark, white is white, gray is gray. So this is a T1. All right, moving on to this next panel. Again, you notice that CSF is dark, but this time white is gray and gray is white. So this is a flare, or a T2 with CSF suppression. On this panel here, you'll note that, again, you can't see the outside of the brain parenchyma very well, and the CSF is bright. So this is poor resolution, bright CSF. This is an ADC. On this bottom left panel, you see all these little white dots everywhere that, and these lines that look bright. So this is a post-contrast T1. We've given contrast, and so these are vessels that are lighting up. This middle panel here has pretty bad resolution. No, you can't see the skin and the bones outside of the brain. Dark CSF. This is an example of a DWI. And then here you have bright CSF. White is gray, gray is white. This is a T2. So once you start looking at these more, this will become more and more natural, but those are just some basic rules to help get you started. And this is just a table that goes through everything we've talked about. Okay, the last thing we'll talk about is a code stroke, or a CT perfusion study. So a code stroke is made up of 3 parts. The first part is a non-contrast study that really helps with a couple things. So the first is to rule out an acute bleed, just like we talked about. If you're looking for intracranial hemorrhage, it's going to be bright on the non-contrast study, and that if there is a bleed, then patients often cannot get TPA. The other 2 signs that you can see, one of the findings you can see is this hyperdense MCA sign. Remember that the patient hasn't gotten contrast yet. So this bright area in a vessel in this MCA is suggestive of a thrombus. There's a clot in this middle cerebral artery. And so that's one of the findings that you can see with a non-con. This case is an example of an established infarct. So you can see that there's this dark area in the right MCA. This is an example of a stroke that's, old enough that you can start seeing it on non-con. The second part is a CTA head-neck. So a CTA, or an angiography of both the head and neck, is used to look for the vessels, obviously. So you want to look for any kind of vascular anomalies. And then you can also identify large vessel occlusions. So here you can see this right-sided MCA looks quite nice. It's nice and smooth, and it's filling completely. Whereas on the left side, you see all of a sudden that there's a cutoff here. So this is an example of a large vessel occlusion. The neuro-IR can go in and potentially take that out with a thrombectomy. And then the last part is the perfusion portion. So the perfusion portion has all these color images. There's a bunch of different parameters that we can use. but really the two main ones that we want to focus on are CBF, or cerebral blood flow, and Tmax, or max time. So the pink images over here show you this volume here is the core infarct. That is the amount of dead tissue. So that's the amount of tissue that has died and there's no recovering it. The green side over here shows you the core plus the penumbra. So that's the amount of tissue that's actually dead, plus the area that is ischemic, so it's at risk of dying, but it's not quite there yet. And then if you subtract these two, so if you do the core plus penumbra minus the core, that'll give you this mismatch volume. And this value here is the penumbra. So this is the amount of tissue that could potentially be salvaged if intervention is possible. So oftentimes neuro-IRs will look at this number to see if it's worth it to go to thrombectomy or to do an intervention. Because if this is a high volume here, then that might mean that thrombectomy has a very, there's a potential for a lot of benefit. Whereas if this is a very low number, a lot of tissue has already died, so there's no getting it back anyway, even if they were to go in and intervene. Okay, so this is just an example of a DWI, ADC, and a flare. You can see this bright on DWI, dark on ADC, and there's no signal abnormality on flare. In the right MCA, this is an example of restricted diffusion. So this is an infarct in the right MCA territory. Okay, so this is what we've covered in my section. We talked about abdominal radiographs being good for a few things. We talked about small bowel follow-throughs. We talked a little bit about CT contrast. We talked about some important findings on CT, abdomen, pelvis. And then we talked a little bit about the brain, including blood in the brain, knowing how to tell what MRI sequence you're looking at, and then a little bit about CT stroke. All right, we will move on. I will pass it on to John.
Thanks, Jen. All right, so just pull my PowerPoint here. All right. So these are my slides. So essentially, I'm going to talk about radiology workflow. I think it's a little bit different than kind of the core radiology concepts in terms of image interpretation. This is kind of talking about how things get done. And then, so, I feel like even though I'm not talking about image interpretation, I should probably show you guys at least one case. So this is a patient, and everyone can just maybe take like 2 minutes to look at this image and think about what you think. It's a patient that's been in a motor vehicle accident, and then so this is their chest X-ray. So I'll just have people take a couple of seconds to look at this, and then just think about what you see or what you would say about this. And then, so I set up the image here, and then here's just like kind of a multiple choice question, broken down into essentially 4 systems that you can see on the chest radiograph. And think about what you would imagine as the most permanent finding in one of these systems here. And then we'll come back to this image a little bit later in the lecture, just something to think about for now. So one thing I think it's important to know is the concept of hidden curriculum. Essentially, during the first 2 years of medical school, we do a lot of textbook learning, a lot of lectures on kind of clinical concepts, but there are things that happen day to day in the hospital that are not really taught to us, unfortunately. And a lot of times, those are the things that help make things go around in the hospital. So then I'll just kind of start with this quote from my internship program director. So he said that the best intern on day 1 is the one who knows where the bathroom is, which I think really puts home the fact that kind of knowing what the logistics are and how things work at an institution is very important. So this is kind of, it's like an exaggeration. I just kind of made a story based on my experiences from internship. Just kind of drive home the different points. Hopefully you guys find this a little bit entertaining. So this is going to be the day one of residency / your sub-internship. So 7:01 a.m., this is when you come in. Your senior resident is obviously busy, and they said they're late for social work rounds. Mr. X, number 3 out of your 6 new patients, had shortness of breath last night. There was a CT chest done, which was negative for PE, but the report did mention there was a 1.5 centimeter nodule. Can you call radiology to clarify if we need to work this up? I don't know how their extension is, but it might be on the whiteboard somewhere. Thanks. So then you look around and this is your whiteboard you see, which obviously is very busy. And then you have this phone here that we're all very familiar with. And then while you're thinking about how to reach radiology, your pager beeps again, and then there's your first page. And then obviously there's a patient with some soft blood pressures, and then the nurse is asking you to come to assess. So welcome to residency. So this is kind of transition into the different radiology sections. It's institution dependent, but most places will kind of separate reading rooms based on anatomy, and then that may be subdivided based on modality. So they will have chest, which, usually there's radiographs that they read, there's CTs that they'll read as well, and then occasionally there's also MRIs that they look at. And then besides chest, body is gonna, when we say body, predominantly we mean like in the abdomen and pelvis. So then similarly, you have CT, radiographs, X-rays, and then you also have MRI. And then subdivided within body, there's also the genitourinary section, so GU. So those typically focus on your urinary tract systems, so starting with your kidneys, going to your ureters, and then going to the bladder, and then also your reproductive systems. And then moving on, next we have neuro. So this is going to be looking for things that we talked about just previously about the brain. So you have CT. You can also have MRI. And then this is kind of an in-between area. So spine, some places is covered predominantly by neuro. Some places will have kind of shared coverage between MSK and neuro, just depending on who's the one ordering the exam. So some places will say if it's an orthopedic order or if it's a PNR order, then MSK will be the one reading it. But otherwise, any other service, it's going to be neuro. Which transitions to MSK here. So then MSK, obviously there's a lot of radiographs, just looking for mostly bony changes in terms of any fractures, anything like that. And then also there's MRI that gives us a little bit more finer soft tissue detail into the findings. And then also there's breast radiology, which, only looks at one area. So it's going to be looking at breast. And then they have mammograms, which gives you really fine spatial resolution. So you can see these micromillimeter calcifications here. And then they also do MRIs to look at the enhancement characteristics of areas in the breast. And then pediatrics is kind of a generalized subspecialty for pediatric patients. So then as a pediatric radiologist, essentially you'll be looking at all types of different films for pediatric patients. So here it's going to be like a radiograph for pediatric patients, and then also you'll have, so this is a head ultrasound, looking kind of like the ventricles here and the parenchyma around it for the brain. And then some institutions, they have a dedicated ER division. So then they look at essentially all the films that come through the ED. And then, some places may have 24/7 coverage, some places may only have daytime coverage. And then, well, there's also a PET CT, so essentially like an oncology division, where they primarily focus on using radioligands to kind of see the uptake of cancers and to kind of stage and evaluate treatment response. And then you also have a dedicated cardiac section. So this is going to be looking at all sorts of cardiac imaging. So most of those are going to be CT of the heart. Some of them look for coronary calcifications, some of them look for more detailed anatomy, and then you also have MRIs of the heart as well. And then finally, we have ultrasound section, which looks at ultrasound of everything in the body as well. So one thing I found helpful during residency is that there's a directory of different reading rooms. So this is the one I took from my residency, where they have all these 5-digit extensions that you can get to reach every single reading room based on modality and body part. So I think like having something like that is super helpful. It's a difference between having to dial the general number and getting passed around between reading assistants and different reading rooms, versus just being able to directly speak with radiologists. This is something that possibly you can call the reading room and just ask for some numbers and then make your own and say, okay, well, these are the rooms that I need to talk to, and have that handy turning around. Um, I think that as an intern was very helpful in terms of, if they have a question during rounds, that's something you can just call immediately and get an answer for, versus having it being like another thing on your checklist that you have to address after rounds. Okay, so going to the next section. So it's 7:17 a.m. now. Your pager beeps again, and it's the ID fellow paging you, and then he's asking you if you can call IR to make sure the patient's lumbar puncture gets done today. And this is something that that was good to see. Is that House of God, I think, is a good book for people to read. And then one of the rules in it is that if the patient is the one with the disease, I think residency sometimes becomes very overwhelming, and then sometimes you may even feel disoriented. But just kind of remember that you're there to help the patients. So this is just going over procedures done by radiology. I think as a medical student, especially early in medical school, you don't really think that radiology is a procedural specialty, but there's actually a lot of procedures done by radiology. So just starting off with body, so fluoroscopy is very frequently done, just looking for evaluation of the esophagus and the small bowel and sometimes colon. We also do tube checks. So essentially, if they have a G tube or any kind of tube, you can check for patency to see if it's working or if it's in the correct location. Essentially, just injecting contrast into the tubes. And then also, body does acid drainages. So anywhere in the body where there's a fluid collection, you can put a needle into, either under CT or ultrasound guidance. And kind of similarly, if there's a mass somewhere, they can also take a sample of it and send it to pathology. So you can either do that with ultrasound or CT for guidance. And then in terms of nephrostomy tubes, so there's an obstruction in the kidney outflow tract. They can place a tube to relieve that. And then periodically the tubes will get clogged. So then again, they either routinely have to come in to do an exchange, or if they're symptomatic, then they have to come in for an exchange as well. And then other things the body radiology can do, they can treat cancers, especially in patients who are not ideal surgical candidates. So they can essentially use CT guidance, put a needle where the tumor is, and then kind of turn up the heat. So there's heat transmitting to the needle and ablate a tumor that way. And then we also work with radiation oncology, where they have brachytherapy beads used for their radiation therapy. And then they asked us to place the beads. Essentially, you're doing the same thing where you're putting a needle there for access, and then the beads are placed through that way. And then similarly to body, chest does things with CT guidance as well. So you can biopsy a lesion in the lung, and then similarly, you can do ablation too for lung tumors. For neural, you can do lumbar puncture. Essentially, you're using kind of fluororadiograph to look for a space to access the spinal canal. So then you put a needle inside here. And then that can either be for diagnosis purposes or can also be for therapeutic purposes. And then you can do a myelogram, which essentially is the same thing as a lumbar puncture, except for now you're just injecting contrast directly into the spinal canal. And then once the contrast is injected, you do some maneuvers with the patient, you can tilt them just to let the contrast go to the entire course of their spinal canal. This is typically done in postoperative patients who have a lot of metallic hardware, where MRI is not great at evaluating what they're looking for, and then so you can do CT. And then finally, you can also do intrathecal chemotherapy, where it's the same thing where you do a lumbar puncture, and then you give chemotherapy agents through the needle on the lumbar puncture. MSK, there's also procedures. So we do joint injections and aspirations. Typically for people with degeneration or arthritis, you can use fluoroscopy to put a needle inside the joint. Typically we do hips and shoulders most commonly. And you can give them long-acting steroids that provide people for up to 3 to 6 months of relief. Also for younger patients, we can also inject contrast into the joints to get distension of the joints and better evaluation of their structures inside the joints, especially the labrum. So that's something we do under fluoroscopy. And then also in terms of bony biopsies, MSK can also do in terms if there's a lesion in the bone, or if we're doing a kind of general bone marrow biopsy for someone suspected for leukemia or some sort of blood disorder. Those things can also be done with CT guidance. Also for breast, to diagnose breast cancer, essentially you need tissue sample. So there's different modalities to do that, depending on what you're seeing. So essentially if you see a mass, that most likely you'll use ultrasound to do the biopsy. And it's a little bit easier and more straightforward to do than a stereotactic biopsy. But for stereotactic, essentially if you see calcifications that you can't see on ultrasound, then you would defer to here, and then this is essentially using X-rays in different angles, and then to biopsy calcifications. So moving on to the next part. So unfortunately, your page rebukes again. It's only 7:26. So someone says the CT abdomen pelvis for Mr. P still has a prelim result. Can you please check when it will be finalized? Although you have no idea who Mr. P is. So this kind of goes back to what Bianca was talking about earlier in terms of the radiology schedule. So most institutions will have different schedules based on daytime and overnight. During the daytime, everyone's there working, so every subspecialty is available. If you wanted to call a neuroradiologist to chat about a brain MR, you can. If you wanted to talk to a musculoskeletal radiologist about a joint MR, you can do that as well. You have mostly routine procedures done during the day where patients schedule as an outpatient to come in for a procedure. And you also have many technologists available, so everyone's able to do ultrasounds, set up procedures, things like that. For overnight, there's very few people available in the department. Essentially, most institutions will have an on-call resident. Some places you may have an attending with them for an overnight attending interpretation. Because it's overnight, obviously there's no patients coming in for routine procedures. So most of the procedures done are going to be emergent procedures that are coming through the emergency department, or if something acutely happens with patients in the inpatient. And another thing is that there are fewer technologists available. So, if you think about getting a scan, the technologist is the person running the sequences or doing the ultrasound. So less technologists available overnight. That also means that the number of studies done is less overnight. So that's like one of the other differences. So here's kind of a breakdown of different types of call for residents for radiology. One of them is going to be fully independent call. So this one essentially, you're the only radiologist or radiologist trainee at night. There will be preliminary studies, and then these studies will be read by the attendings in the morning. And then the reports can be very different in terms of what a prelim report entails and what a full report entails. So for example, a prelim report is just going to talk about presence or absence of emergent findings. And then the more non-acute findings will be discussed later in the full report. So something might be like, there's no bowel obstruction in this patient. And then the next day when the attending gets there, they'll probably say, no bowel obstruction, but then there's more non-urgent findings or non-acute findings, like the metastatic cancer scores. So that's fully independent call. Next category is what's partial independent call. So again, there's only the resident there, but there's an option to send studies to a teleradiology attending. So if there's a very difficult study or something that's requesting it to be urgently final sign for a procedure or a surgery on the patient, then they have the option to send the study to a teleradiology attending who can final sign that overnight. And then finally, there's non-independent call. So for this type, both the resident and the attending are available. So then, the workflow is still similar in terms of the resident is the one looking at the studies first. So the studies will be prelimed by the resident, and then within, depending on how fast the turnaround is, sometimes it's, within a few minutes or half an hour. Sometimes it can take a few hours. The studies will be overread by the attending. And then the other thing, I think for those of you guys who's been on clinical service already, and you've gotten calls from radiology, sometimes we'll ask for your name. This is not something that, we're like trying to get your name for other reasons. It's just that based on the way things are set up in the hospital, if we report a critical or acute finding, then we have to document who we spoke with, or any kind of overreads. So kind of like what I talked about earlier, with call, if there's change when the attending arrives in the morning and then they makes a change on the report, then they have to document what they spoke with. Okay. So next section, your pager briefs again. So you get a page from nurse saying, Mrs. S doesn't want to go down for the CT scan today because she doesn't want to lay flat. Can we change it to an ultrasound? Is that better? Please advise. And this is definitely not something I learned from UWorld. So this is something talking about spatial resolution and contrast resolution. I think like as a med student, you typically have a paradigm in your head that X-ray is the worst, ultrasound slightly better, CT is better, and then MRI is kind of like the best modality, which is not entirely true. So something they teach us in radiology is that there's kind of ways to classify the way how good an image is. So the first one is spatial resolution. Essentially, it's being able to distinguish two different structures from one another. It's like the degree of blur or sharpness on the image. So if you're on the left-hand side here, you'll see that this image is very sharp. You can see the borders of the structures very well. So then this will be something with high spatial resolution. And then on the right-hand side, you can see this is very blurry. It's very hard to see the borders. So then this is going to be something that's low spatial resolution. And then this is different than contrast resolution, which means how well can you distinguish two things that are next to each other based on their tissue characteristics. So if you're looking at A in the row above here, you can see that like even though there are two boxes here, you can't tell the difference. You only see black. And then here, it's also very difficult to tell. I mean, it's subtle, you can see it, but it's definitely more subtle than the row below. So top here is going to be poor contrast resolution. Whereas in B, essentially you see that you can very easily tell there's two boxes next to each other. So in this case, this will be a study with high contrast resolution. So now I want you guys to kind of think in your head in terms of like these are going to be the general modalities that we use in radiology, what the spatial and contrast resolution is for each of the exams. So this is essentially how the modalities are rated based on spatial and contrast resolution. I think it's a little bit against like that paradigm that people in their head that MRI is the best because the spatial resolution for MRI is actually not as great as something like CT or X-ray. So just to give some examples of this. So here we have different modalities for breast imaging. Here's a breast MRI here. This is an ultrasound of the breast, and then this is a mammogram, which essentially is an X-ray. Um, so in terms of spatial resolution, you can see that the X-ray, you can see these sub-millimeter calcifications within the breast tissue itself. These are things that you cannot appreciate when it's on an MRI or sometimes even the ultrasound. But the contrast resolution on an MRI is much better than an X-ray. And what I mean by that is that when you look at the X-ray, essentially, you have some fat, but then you just have like these blurry, more bright areas here. Um, so it's kind of hard to tell exactly what is what within the bright areas. But on the MRI, you do now see the glandular tissue is very, very well distinguished from other tissue adjacent to it. And then here's another example in the pelvis. So again, you have radiograph here, so this is an X-ray here of the pelvis, and then you can see the spatial resolution is really good in terms of looking at the bones. You can see the cortex of the bones really well. So the essentially like the microscopic details are really well seen, but the contrast resolution is really poor because essentially you just see the soft tissue fullness in this area. You're unable to distinguish anything in terms of what is actually in here besides soft tissue. And then you move to CT, which is better than X-ray for contrast resolution. So it's kind of in the middle here. And you can kind of sort of make out some structures and differences, but it's still not as good as the MRI, where now you can definitely see the different types of structures. The different detail is not as well. So if you're focused on the cortex here, so this is the bony cortex of the acetabulum here, you don't see as well as you do on the X-ray here. But if you're looking to differentiate different types of soft tissue from the adjacent one, so if you have your seminal vesicles here, your prostate here, your bladder wall here, these things are very well distinguished from each other based on the high contrast resolution. Um, so that's kind of just like an introduction for spatial resolution and soft tissue contrast. And that's something that I just a little bit think about to provide some nuance into, the different imaging modalities within radiology. The other thing we think about is how long it takes to complete these exams. So again, it's kind of the paradigm I had as a med student was that, probably X-ray is the fastest, and then, kind of gradually the better exam takes longer. And I think that, is not completely true either. So I just have you guys kind of think about in your heads how long it typically takes to do one of the exams. So, X-ray is very fast. Taking an X-ray only takes a few seconds. But I think what was really surprising for me to learn was that, CT is actually pretty fast. Most of the time, it's actually just getting the patient set up on the table. The actual scan time is actually quite short. And then ultrasound is very user dependent. So, a fast technologist can scan fairly quickly. It also depends on the body habitus of the patient as well. And then MRI takes the longest. There's different sequences, and then each sequence takes some time to acquire. So just like that's something to point out there. So going back to next part. So it's 7:55. You made it back. You see your senior resident. They asked you, did you call radiology about Mr. X? Anyway, can you also call IR for Mr. Y? Social work says the SNF authorization expires today, so we need to have a ton of flying place before discharge at 2 p.m. So good thing now you have your numbers, and then you can call IR. So this is something I think it's similar to any other service with consult in the hospital. There's a lot of things that are good to have, but essentially there's three things that I think are very important to have. Everything else we can look at too. We also have access to the chart. So I think as long as you convey these three things, that's going to set things in motion for the patient. The patient's MRN, who they are, callback numbers so we can get back in touch with you, and then what procedure you're trying to do. As long as you have these three things, then we can start looking at the chart too and seeing if there's availability or if the procedure is indicated. Other things that are good to know are going to be anticoagulation status. Is the patient on anticoagulation? NPO, have they eaten today or yesterday? Can we give them any kind of anesthesia based on that? The patient's INR and platelet count. So in terms of, it's similar to coagulation status. Their clinical status. Is this someone that's, on the floor that's fairly stable that we can bring them down without nursing assistance? Or is this someone that's in the ICU who's going to need, a lot of assistance bringing down to our procedure suites? Any prior relevant imaging that the patient has that we can look at. And then if there's any other procedures planned for today, for example, if the patient's going for dialysis at 2 p.m. or if they're going for endoscopy later, that's something to know about just in terms of scheduling. So then this is going to be from the SRI consensus guideline website. It kind of breaks down procedures into categories based on the bleeding risk. So on the right-hand side, you see these are going to be high-risk procedures for bleeding. So things that you imagine like a TIPS procedure, biopsies into highly vascular organs like the kidneys, kind of like biliary interventions, things like that. So for these ones, typically we want the INR to be less than 1.5. So these are going to be more strict recommendations for coagulation. And then on the left-hand side is going to be more simple procedures. So for taking out the central line or doing a joint aspiration, then the requirements are not as stringent as what it would be for these procedures. And then you kind of have some procedures in the middle and the intermediate area. And then this is also just another paper going in terms of if the patient's on an anticoagulation agent, and then based on the category of procedure that we outlined here, when can they resume their anticoagulation? And also when you should stop anticoagulation beforehand. So essentially, like, sometimes we'll get calls of, oh, like, when can we start their warfarin or aspirin? This is essentially, we just pull up this chart and tell you. The other thing about IRS scheduling is there's, different rooms that attendings are in doing the procedures. During the day, they have outpatients have already scheduled procedures ahead of time. And then there's, time turnover between getting the patient into the room, doing the procedure, getting the patient out the room, cleaning the room, and then calling for the next patient. And then, sometimes there's going to be kind of blocks open, and then that's typically times where we can fit in any inpatient requests for non-emergent procedures. Obviously, if there's going to be an emergent GI bleed or anything like that, then we have to kind of pause on the outpatient and then put the emergent case in. But yeah, this is when, when you guys call and saying, okay, I have a patient who needs a central line today, things like that. Then we look at the schedule and see if there's room we can fit them in. Okay, so now it's 9:30 a.m. It's time for your first admission. It's an outside hospital transfer for a second opinion on a very subspecialty procedure after an extended and complicated course at the outside hospital. Maybe you'll consider doing radiology for your upcoming two-week elective. So this is where we talk about radiology rotations. The way I think of it is it depends on the person coming in to rotate with us. It's the first was going to be kind of the medical students coming in who are not going to radiology. It's just part of their fourth year rotation. These students, I usually just let them go very early in the morning. If they want to stay, they can of course stay. And I think these rotations are good just to get used to the workflow of radiology. And then like in terms of specific exams in your own specialty that are going to be with radiology, it's good to kind of recognize critical findings that you might see on X-ray or CT. And overall, it's a very flexible rotation. I think it's, the clinical rotations can have long hours, but I think radiology is kind of a nice oasis from that. So I typically dismiss students fairly early, and there's not a lot of expectations. And then these are just kind of some good learning resources I think for students to look at. I think Felson's is pretty good. It's kind of like a comic book for chest X-rays. So it's pretty easy to read. And then there's also other online resources that have labeled images. And then for IR, it's going to be on the opposite end of the spectrum. It's going to be similar to any procedural specialty rotation that you pursue. Um, and then, so here we talk about the 3 A's of doing well. I'm sure everyone has heard of this already. So availability, affability, and ability. Um, so availability, you want to show up early and stay late. I think that's pretty obvious if you're going on like a trial rotation or like an audition rotation. Affability, get to know people well. I think it's really important to know the residents, know the attendings, but also the support staff who can really make or break your rotation. So getting to know the techs well and getting to know the nurses well, especially like taking the effort to learn their names, I think is really important. Um, and finally, ability. So kind of just knowing if you're scrubbing into a case, knowing the history and then why you're doing this case is very important. The anatomy, it's not a lot of expectations for med students, but just in terms of if you're doing an endovascular procedure, knowing the way you're getting there in terms of the names of vessels, I think is good. And then the other things are just things that people sometimes may not have the time to do, but I think it's good to show initiative as a med student. If you do a procedure on a patient, it's good to check up on them, make sure they're doing okay. And then just, you can even check up on them later through the chart to see, how they're doing. Um, we'll get called for consults. So you can help with consults in terms of, taking a phone call and then kind of just getting the relevant information for that. And then a lot of times when you're scrubbed in, you probably won't be the first operator or sometimes not the second operator. But it's always good to know the steps for the procedure. Once you've seen it a couple times, you kind of get a rhythm in your head of, well, okay, we're doing this now. What's the next thing to do? And you can grab something from the table to hand to the resident or the attending. This shows them that you are also, taking part of the procedure and you know what's going on instead of just standing there. And then, if you hand them the instruments, you're like, okay, you clearly know what's going on, which goes into managing the back table here. I'll talk about. So this is going to be kind of a typical back table for IR. So you have your sharps places here, and then you have this bucket here. So this is going to be filled with saline. And then you have, your wires are going to be hydrophilic and hydrophobic. So then the ones that are hydrophilic, you want to put in here so they don't become sticky. And then they also have a bucket, kind of this white bucket here. So essentially to opacify the vessels for endovascular procedures, you inject contrast into your access site. Depending on the operator, the ratio of contrast to saline is different. Some people may like 30% contrast and 70% saline. Some people may like 70% contrast and 30% saline. It just depends on how much they want the vessels to be opacified. So kind of obvious if you give more contrast, it's going to be darker or opacifies versus if you get less contrast. So that's part of the job, just to keep syringes ready where they, reach out their hand, you can hand them the syringe that's mixed to their preference. That's something that's good. And then also if there's other equipments like wires, catheters that you can hand out to them, kind of sponges, things like that to be helpful. And then the other thing is obviously to be mindful where the sharps are. The worst thing you can do is kind of like cut your resident attending where you're helping out. So just make sure all the sharps are deposited into the right place and everyone's safe in the environment. And then finally, so this is going to be the third. So this is going to be if you're a student that's going to diagnostic radiology and you're doing a rotation. I think this is kind of a challenging rotation in terms that there's not a lot of things you can do to stand out in the rotation. We don't get patients assigned. People don't ask you about history on the patient. Usually you just sit behind either a resident or attending, and then it's hard to kind of make yourself stand out. These are the things I put in here. So one thing is to always look engaged. I think especially, in August and September, we understand that there's ERAS going on. You may be getting interviews or urgent emails. But just letting people know what you're doing is good. It's bad if you're just on your phone and people don't know what you're doing. Maybe you're just on Reddit or doing something else, but you can let people know I'm actually like trying to schedule an interview. I think most people understand if you're doing that. I think this second point is a big pitfall for medical students when they come for diagnostic radiology rotation. Um, it's not really a knowledge-based rotation. You'll never impress someone to the point where they're like, oh, we have to match you just because you know so much about radiology. It's just because it's a long residency, and first there's really no expectations even for R1s coming in. Um, so I think what's good to focus on is kind of like talking to the people you're working with and getting to know them. And then just kind of knowing where they're from, and especially going to another point here is that if you have a location or preference or reason why you want to be in that area, like maybe if you grew up there or if you went to college there, those are things that are very helpful and can be advantageous for you, for us to know. And that just kind of goes along with getting to know them so they get to know you. And I think the whole point of the rotation is that once you're there, people can know you as like who you are and not just name on the spreadsheet or like your scores. Um, and then the other thing I think is helpful is doing a small research project when you're there. Um, I think this gives you an opportunity to work one-on-one with the attending, and then they can kind of gauge your work ethic that way, right? Like if you're, doing all the tasks on time, you're going out of your way to look for things for research and, doing a great job writing the abstract or paper, that's something that can really shine during your rotation. So one thing or tip I think I have is, looking for conferences that have deadlines around September, because that kind of gives you a deadline that you're going to have something submitted by this point. So the project doesn't drag on, and you can come away with like a abstract or like an acceptance at that point. Um, and then finally, the thing is to remember is you're also evaluating the program too, in terms of are the attendings friendly with the residents? Do the attendings go by their last names or first names? Do they talk about things besides radiology in the reading room? These are just things that to see what matches to your preference. So that's also something to look for too. So now kind of going back to the image that we had before. So this is that patient that was after a motor vehicle accident. So the four categories here we have are cardiovascular, respiratory, gastrointestinal, and musculoskeletal. And I think this is a good case in terms of, having clinical information is very helpful. I think almost everyone looking at this case, what's gonna take focus their attention to is gonna be up here. Obviously, there's gonna be opacity in the left lung area. Um, so I think people may think it's a respiratory or cardiovascular issue. So if I give you one more piece of clinical information, let's see if that changes your opinion for the case. So this patient's been in a car accident, and then they're on a neurosurgery service. Now you may ask yourself, why are they on a neurosurgery service with a finding like this, right? That doesn't make any sense. So this may prompt you to look for other findings on the image that may explain what's going on. So if you look here, the spine is actually dislocated here. It's not something, I think it's something that if you don't have a good system of looking at everything in the image, this may not be something you notice, which, is very debilitating in this case. And then here's the CT on the same case. So essentially this is a spine dislocation. The patient actually came in paraplegic from this, hence being on a neurosurgery service. So this kind of just really highlights the importance of providing the clinical information you can to help us look for things. Okay, so then this is going to be for the few people who are, going to radiology or applying for radiology, kind of talking about like what happens during the first year of radiology. So you decide to apply for radiology after being let go at 10 a.m. every day during your radiology rotation. Learning about the fascinating anatomy and pathology on your radiology rotation. And now you're starting R1 year. So I think a lot of people, when they go from internship to R1 year, there's a big change in terms of what they do and also the confidence. Most people by the end of their internship feel very confident clinically in terms of if they were to stay on for internal medicine, they could probably do it and finish through. And then they feel day to day they can handle things coming through pretty well. But going to radiology, essentially you're starting with zero knowledge base. So again, you don't really know much. So that could be a big change in confidence. The other thing for clinical medicine is that, as everyone been through med school would know that you would have different teams that you go with on clinical services. You have, med students, you have an intern, you have residents, sometimes fellows and attending. It's a very well organized structure where people are responsible for patients, doing presentations, things like that. On radiology, you're in a reading room and you're working with attending, but it's not really a formal structure. There's no kind of assigned cases or anything like that. So it's less of a formal team structure. And so starting in R1 year, most programs you'll rotate through most of the subspecialties. In places I've been to, you usually do 4-week rotations at once. Essentially, this is going to be just enough time for you to feel comfortable about the rotation. And then as soon as you feel comfortable, you're going to go to the next one where you know nothing again. And then you kind of just rinse and repeat this for about 2.5 years until you become comfortable. And then you take your radiology boards. So the day-to-day, most places you'll come in and you look at studies on your own first, and then you draft a report. And then once you have some ready, then you go over to attending and you guys kind of talk about the cases, and then you edit your report based on what the attending says. And then there's dedicated educational time. So some programs will have morning conferences that are, maybe 7 to 8 or 8 to 9. Some places have noon conferences between 12 to 1. And then some places we have like afternoon conferences. So for residency, we had like 12 to 4 on Thursdays were blocked off for conferences. In the reading room, the junior person is typically the one who answers the phone calls, which is very kind of paradoxical because you're the person who knows the least. Um, but I think it's good practice for a call when you're the only one there. So don't be afraid to ask seniors or attendings if there's a question that you don't know about. And then now you're on the other side of being consulted, but still the 3 things that you want to get. So get an MRN, what kind of exam they want, and a callback number. As long as you have these things, anything can pretty much be resolved by chart reviewing or calling them back. So just, even if it's a really complicated question, as long as you can get these 3 things, then everything else can be worked out. Most programs have no call R1 year. I think it's a really nice time to go from being on call a lot during internship and then pretty much having all your weekends and holidays during R1 year. But you're paying it back because there's so much to learn. You're mostly studying a lot on the after work and on the weekends. And then typically in January every year, there's going to be an in-service exam that's kind of standardized nationally. But most programs don't really pay attention to this data. It's kind of something for you to prepare for yourself for the core exam in 3rd year. So now for things outside of clinical practice and radiology. So starting R1 year, most places will let you moonlight. So this is a great idea to make some extra money. Most places will do contrast injection coverage. This means that a patient's getting a scanned contrast. They need a doctor there to monitor in case there's any issues. Then the contrast reactions are typically very rare, usually less than 1%. And some programs say you can start 1st year. Some programs ask you to start in the 2nd year, just depends on the program. Conferences, I think it's really good to attend conferences in residency, just to, network and meet new people. And it's good to have some time off too. So these are kind of like the national conferences. RSNA is usually the biggest conference for radiology. And I think like for most specialties considered, it's more formal than the other ones. It's very vendor heavy, meaning you have representatives from Siemens or GE coming in. And it's always in Chicago in November. So it's pretty cold usually. ARRS. This is a more smaller, more informal conference, and then it's a lot less vendors there, so there's a lot of just radiologists there. And then you have your subspecialty specific conferences. So for neuro, MSK, body, breast, you have their own conferences you can go to. Fellowship applications. So radiology fellowships are very uncompetitive. You can pretty much walk into any fellowship you want, coming from any residency program. So you don't have to feel as much pressure to create an app for fellowship. If you're interested in research, that's something you can do, but it's not required to match into fellowship. And that's all I have.
Okay, thank you so much for attending today's radiology boot camp. We have about 10 minutes left, and I know a lot of people have asked questions in the chat. But if there are any questions that you want to ask now, feel free to turn on your video, unmute yourself, and ask a question. You can also send the questions through the chat as well. So a big thank you to our wonderful speakers. And speakers, if you are comfortable with sharing your email address in the chat, that would be really wonderful. The session, as Elise had mentioned, is recorded and it will be on the APAMSA National YouTube page. And if you'd like a copy of the high yield speaker slides, please fill out the feedback form, which I will send in the chat in a minute. This is the second to last session of the Bootcamp series. There's going to be one more Bootcamp series event tomorrow, which is family medicine. I hope you all enjoyed this session. I know I sure did, and I learned a lot. I especially enjoyed the last sort of like workflow of understanding what it was like to be working from like the medicine standpoint with radiology, because I think almost everyone here will experience that.